Hi, my name is Arunwan Pratipan. I'm the president of the Asian Pediatric Pulmonology Society, as we call APPS. It is my great pleasure to welcome you to our third APPS, in which we are going to have another interesting case to be presented and discussed by the experts. I would like to express my sincere thanks to Malaysian Thoracic Society to co-host this grand round, especially the President, Associate Professor Muhammad Iswanuddin Ismail, and the Secretariat, Ms. Suha. I really appreciate all volunteer speakers who have pushed efforts to deliver the best possible grand round to all of you. We are lucky to have Professor Anna Nathan to be our moderator today. So let me introduce her first. Professor Anna Nathan is consultant pediatrician and pediatric respiratory physician in University Malaya, Kuala Lumpur, Malaysia. She is well trained in pediatric respiratory medicine, sleep medicine, and allergy. She has published more than 70 articles in peer-reviewed journals. She also very active in teaching and research. So please welcome Professor Anna Nathan.
Thanks so much, Arunwan, for your kind words, and welcome everybody. Thank you so much for taking your time off this precious Friday night to join us and learn something new. So today, I'm proud to introduce that the Malaysian team, will be taking you through an unusual case of a very noisy toddler. But first, let me introduce the team. First, presenting the case, I have my good colleague, Professor Ik Kaping from the University of Malaya, who is a very experienced pediatric pulmonologist. We also have other three experts who will be commenting on this case. The first is Prof. Jayanti, a pediatric otolaryngologist of 9 years experience, and someone who we work very closely with in University of Malaya. We also have all the way from Ireland, Prof. Basil from Trinity College Dublin. He is a consultant pediatric respiratory medicine consultant. Now, finally, we also have Prof. Gary Wong. Many of you will need no introduction to Professor Gary, epidemiology of allergy and asthma in children. So to Prof. Ik to present this case. Ik.
Okay. I need to share the screen. Hold on. Okay. Can you see my screen now?
Yes,
Yes, do you want to put in
a
slideshow? Slideshow.
Can you see now?
Yes, excellent. Go ahead.
All right. Okay. Thank you, Prof. Anna. Good afternoon or good evening, everyone. It's my pleasure here to share with you a case today. A very noisy toddler. What could it be? This child was referred to us early this year when he was 14 months old. He has recurrent noisy breathing since the age of 6 months. His first presentation was at 6 months old, which was last year, May. He presented with fever, cough, and runny nose for 3 days, rapid and noisy breathing for 1 day. There was no previous noisy breathing, no vomiting, no history of inhaled foreign body, no choking during feeding, and no interrupted feeds. He had no eczema or food allergies. At that point of time, his parents also had cough and cold. His other personal history, he had an uneventful antenatal period. He was born premature in another hospital at 34 weeks gestation with a birth weight of 2.3 kg. He was intubated after birth for 1 day. We were unsure of the ETT size and we are not sure if there were any difficulty in intubation. He was then extubated a day later and discharged well after 1 week. His immunization schedules were up to date and his developments were normal. He was fully breastfed and started weaning at 6 months old. His father is a 40 years old mechanic. He is a smoker with chronic asthma and allergic rhinitis. His mother is a 35 years old lady who worked as a hospital attendant. He was taken care by a babysitter who also looked after 2 other children, and she had cats in her house. During this January 2024, his initial examination showed he was noticed to have barking cough. He was not tachypnic and saturating well in air that time, afebrile, but he had mild chest recessions and the lungs had generalized crepitations and bronchi. His heart sounds were normal. His chest X-ray showed hyperinflated lung field, but otherwise there was no obvious consolidation. His nasopharyngeal swab taken and detected SARS-CoV-2 virus and also respiratory syncytial virus. The diagnosis made was COVID-19 category 3 with RSV group and bronchiolitis. He was treated with nebulized budesonide and salbutamol inhalers at the emergency department. He was then transferred to PITS ICU and put on nasal CPAP with oxygen for 1 day. He was also treated with IV dexamethasone and ampicillin, and subsequently he was discharged well on day 4 after admission. After the admissions, he was still having residual dry cough about 1 to 2 times a day, but mother reported no rapid or noisy breathing. A month later, he was readmitted for worsening cough for 4 days with 1 day fever. He also noticed to have a noisy breathing for 2 days. And during this point of time, the examination, the doctor who examines heard inspiratory stridor, and he was diagnosed as acute croup. This time, the virus detected was metapneumovirus. He was treated with budesonide and oral dexamethasone. He was given nasal oxygen for 1 day and then discharged again after 3 days. Subsequently, he had multiple emergency and admissions. He was seen 2 weeks after the admission. He had no more cough at that point of time, but he was noticed to have persistent stridor. He was then referred to our ENT colleagues. And that was in July last year, actually, sorry. And he had noisy breathing since May and for RSV and COVID-19. And during that ENT clinic review, he was noticed to have stridor when crying and when got excited. They did a flexible nasal pharyngoscopy for him. He was reported as mildly curled epiglottis. Arytenoids fell inwards on inspiration. He had mobile vocal cords, adenoids occupying 60% of nasopharynx, but there was no intranasal mass or polyp seen. He was diagnosed as mild laryngomalacia. And 2 months later, he had another 4 ED visits in September last year. He was, the first 3 visits were the same illness, whereby he was diagnosed as acute bronchiolitis and croup, and he was also given budesonide and dexamethasone. And 2 weeks after that illness, then another episode of bronchiolitis. And at that point of time, he was also noticed to have stridor, but the doctor thought that was because of the underlying laryngomalacia. A month later, he was readmitted again, whereby he presented with fever and cough for 3 days and also stridor. So again, he was diagnosed as mild croup, treated with budesonide and dexamethasone. Virus this point in time is parainfluenza and also human rhinovirus. Again, in December, he had 2 other ED visits, and he was also treated as acute bronchiolitis. There was also stridor at that point of time, but it was not worsening. In between this ED and admissions, he also had 7 clinic reviews. And for the following problems: mild laryngomalacia, recurrent croup and bronchiolitis. He was also diagnosed clinically to have cow's milk allergy based on the 2 encounters whereby he developed rash after consuming some cow's milk at about 10 months old. And however, there was no confirmatory test by any allergy testing. He also had failure to thrive and also iron deficiency anemia. And during these clinic reviews, there are some times that doctor encountered that he had no noisy breathing, but there were some reviews that stated that he had mild inspiratory stridor. These are the chest x-rays for all the visits. His initial chest x-ray was just hyperinflation, but subsequent chest x-ray shows airspace opacities over the right medial lobe, but there was no obvious tracheal narrowing. And a bit more detail on his latest admission, which is during the January. He presented with cough and runny nose for 3 days and rapid breathing for 1 day. His saturations were normal and his vitals were all normal, afebrile. He's mildly tachypnic with a respiratory rate of 48 breaths per minute with some intercostals and subcostal recessions. He had good cry with audible stridor. There was occasional crepitation, but no rhonchi on the chest auscultation. He was diagnosed as viral croup with pneumonia. And this round, he had parainfluenza virus detected again. Besides that, he also had a nasal pharyngeal secretion that grew pneumococcus. He was treated with nebulized budesonide, hypertonic saline, and suction, also given dexamethasone and a course of antibiotic. He was started on nasal CPAP, which improved his stridor and recessions. His chest x-rays this time was under-inspired, but they still can see some airspace opacities over the both lower zones. His investigations shows no CO2 retention. We do not have cap gas, but it's just a venous blood gas done in ED. There's no CO2 retention. His super count shows hyperchromic microcytic anemia, differential, so no eosinophil, and his IgE was normal. His other workup, like for immune screen and TB workup, was normal. And he was planned for a skin prick test as palpation for the cow's milk allergy later. This is his growth chart that showing that he had failure to thrive, very poor weight gain after 6 months of age, whereby the weight was static, and he was then referred to dietitian and was added some energy booster to his diet, and his weight subsequently catch up. And during the last 2 visits, it's catching up to the 3rd centile. So this is the time when we saw him in January after we removed his CPAP. This is how he sounds like. So I replay. Okay.
Okay. So I hope you all managed to hear the what you call it, the noise. So now is the first poll for today. I would like all of you all to participate if you can. What state the noisy breathing that is heard in this video? Do you think it's stertor, inspiratory stridor, expiratory wheeze? Is it biphasic stridor? Or does this child actually have stertor and wheeze? I'll give you a few seconds. Okay. Let's see whether I can go up to 100% participation. Okay. Okay. Okay, people still answering. Still answering. Okay, so I think I'm going to end the poll. Okay, and we can see how many of you all have answered. Very good. Most of you all have caught the sound. So I can see most of you all have labeled this as biphasic stridor. The next one obviously is inspiratory stridor, and the rest stertor, expiratory wheeze. Okay, so if we go to the next slide. So yes, so we actually thought that this child actually has biphasic stridor. Yeah, so let's play again for you all to hear again. Okay, yes. So if you can hear a sound both in inspiration and expiration. So with this noise and with this history that we've showed you, I know there's a lot of data for you all to crunch in. So, but perhaps you all can hazard a guess. What do you think is the most likely diagnosis for this recurrent noisy breathing? So the next poll question will come up again. Could this be viral episodic wheeze or multiple trigger wheeze or preschool wheeze? Do you think that this is just the laryngomalacia that's playing up? Could this child actually have some sort of a recurrent croup? Could there be some congenital airway anomaly? Could this be post-infectious bronchiolitis obliterans because he did seem to, everything happened after the RSV and COVID? Or do you think that there is some reflux disease? Okay, so we are 50% of participation. Let's see whether we can get it a little bit higher. Okay, so let me show you the results. So what did people really think? Interestingly, yes, so most of you all, 50% again, thought that this was a congenital airway anomaly. Some thought it could be post-infectious bronchiolitis obliterans. And the next contender, could this be some sort of a preschool wheeze? Could it be the laryngomalacia? So I won't give the answer out, obviously, but I'm just going to pass the baton over to Prof. Basil from Trinity College, Ireland, and he will discuss with you the different types of noisy breathing and what it could be. Prof. Basil?
Thank you very much, Professor Nathan, and thank you for the APPS for inviting me to participate in this very interesting case. So I think it's very prudent now to go and just review what we've heard, respiratory noises. Apologize about that, it's respiratory noises. So noisy breathing is one of the common presentation in children, and it could reflect different diagnoses. The commonest we hear is a wheeze, or sometimes could be a stridor or a stertor. So a wheeze is known to all of us. It's a high-pitched whistling noise, mostly occur during expiration on the exhalation phase, and it reflects narrowing or spasm of the small airways. A stridor is usually a Latin word which comes from stridulus, a creaking or grating sound. And this is caused by turbulence of air due to partial obstruction of the upper respiratory tract, or at times could be at the level of the laryngeal or tracheal levels. It's usually vibratory in character and high-pitched and harsh noise. Now, we know that a stridor typically could be mostly inspiratory, but as well could be biphasic, as what we've possibly heard in this child. Inspiratory stridor generally reflects some subglottic issues, laryngeal mass, or maybe vocal cord pathology. In the context of a febrile child, may reflect an infection. The commonest is laryngotracheobronchitis, or maybe in a very sick child, epiglottitis. Now, biphasic stridor, which usually happens during the two phases of breathing, inspiration or expiration, by and large reflects tracheal problems. It could be acute, sudden, and that could possibly be a foreign body, or if it is a chronic one, reflects a tracheal problem. Now, a third noise that could be confusing at times, which is a stertor. And a stertor usually from a Latin word, stertri, and it means to snore. And this is noisy breathing caused by turbulence due to partial obstruction of the upper respiratory tract, i.e. at the level of the larynx, nasopharynx, or oropharynx. Next slide, please. So this slide, it's very important for us to categorize what age or onset of this pathology. At birth, usually we would talk about vocal cord issues, or maybe a congenital lesion at the level of the larynx, possibly a vascular ring, or laryngotracheal stenosis, depending on what type of stridor it is. And if it happens later on in life, with like what we see in laryngomalacia, it'd be 4 to 6 weeks. But some children might have it even between 1 to 4 years of age. And as I said, in the context of an acute illness, a croup or epiglottitis, or an acute event could be foreign body aspiration. So acute, at this point, just the separation is acute onset reflects either an infectious cause or a foreign body, and a longer duration reflects maybe a structural abnormality at the level of the larynx, or maybe lower down, depending on the phase, whether it is inspiratory or biphasic. Go next slide, please. So this is a long list, and it's by no means exhaustive, but it tells you what upper and lower. Normally, it's an arbitrary distinction between upper and lower. But by and large, if we talk about upper airway, that's the extrathoracic part. These are the different causes that can lead to stridor at the larynx, laryngeal cyst, cleft, hemangiomas, etc. And if we go lower down in the lower airways, tracheoesophageal fistula, tracheobronchomalacia, so extended malacia, tracheal stenosis, tracheal rings, compression by different vascular anomalies, arterial azuria, aberrant innominate, etc. Or very, very rarely in the tumors where you get carcinoids or lymphomas. But this is thankfully a little bit unusual in children. Next slide, please. So when do we refer children for evaluation? So I'm bringing here the term recurrent croup, and I would like to finish later on by that. Recurrent croup is a presentation and should never be a diagnosis. But usually, if a child is having more than 2 episodes per year, or little or no response to the standard croup therapy, or outside a certain age, below 6 months or outside 3 years, certainly would warrant a referral for further evaluation. Multiple hospital admission, as this child we're presenting today, or if the child is having a persistent weak or a persistent hoarse cry. These are the criteria to refer the child for further evaluation. Next slide, please. I'm putting this one here because what is the contribution of gastroesophageal reflux disease to respiratory noises? In different studies, depending on which study you look at, you can have up to 100% of the patient presenting with recurrent croup might have significant gastroesophageal reflux. I would like to point out that gastroesophageal reflux is not a causation, but rather it may aggravate or unmask a pre-existing airway pathology or an airway malformation to present with recurrent croup. There has been different issues about the recurrent spasmodic croup, which is generally a child who's extremely atopic. And you probably noticed that in our child when it was presented, that the IgE there was normal. They pointed out no eosinophils, and a skin prick test was planned for that child, specifically to rule out any other atopic condition. Because reactive airway disease was thought in about up to 82% of the patients that they may present sometimes with recurrent croup. However, I would like to highlight here that this is just a relationship rather than a causation. Next slide, please. And I'll finish by this study, which was a retrospective study published from the Royal Hospital of Sick Children in Glasgow, whereby they looked at 90 children presenting with recurrent croup to that service. It's a tertiary center. And they've shown 25 children out of the 90 whom have the diagnosis of recurrent croup had anatomical airway abnormality when they were evaluated. 16 of those 25 has some degree of subglottic abnormality, be it congenital or acquired. 23 children has positive findings of reflux, and in nearly 40% or so, 45%, there were no cause identified. Sadly, one causation of death there, that child presented in an acute respiratory failure to the emergency department. The measurement of IgE and complement proteins did not show any particular help in the categorizing these children. So I'll finish here by saying recurrent croup may not always be a benign diagnosis, but you have to think about it, and if it is certainly happening quite frequently, needs further evaluation. Thank you.
Thank you so much, Prof. Basil. So let me share with you how we broke down this problem that we had with this child. Okay. So of course, I in the poll, some of you all did mention, could this be an episodic viral wheeze or preschool wheeze? So some points to support this. Yes, this patient came in with episodes of shortness of breath. There was wheezing that was heard in the emergency department, and all were triggered by an upper respiratory tract infection. The patient has food allergy. It sounds convincing from the history. The father vapes and has asthma. But the most important is that this patient, when you hear the noise, it's biphasic stridor. And we know this is not wheeze. And this noisy breathing, was fairly persistent. And there was no response to salbutamol. And this patient had a low IgE and eosinophil. Next. If you think about laryngomalacia, well, definitely we know that this patient presented with stridor. We know laryngomalacia is the commonest cause of stridor. And we did have an ENT scope that showed mild laryngomalacia. But laryngomalacia, again, is usually uniphasic or inspiratory stridor and does not present with biphasic stridor. Another very important point is that this patient did not follow the natural history of laryngomalacia, like Prof. Basil mentioned, whereby laryngomalacia normally presents when you are young, when you're 4 weeks old, sometimes 2 weeks old, and it tends to get better with age. And this is not what we see in this patient who it suddenly appeared at around 6 months and seemed to be getting so many attacks or, so many episodes. Next. So, of course, airway anomaly, and most of you all actually, nearly 60% of you all thought that this could be an airway anomaly. So let's look at the types of airway anomalies. Could this be a tracheal stenosis? So we know Prof. Basil mentioned that a majority of biphasic stridor is something to do with the airway. And definitely it could be, because tracheal stenosis can present with biphasic stridor, with wheeze. The chest X-ray didn't show any tracheal narrowing, but still it could be a diagnosis. Could this be some sort of vascular sling? And yes, again, vascular slings do present with biphasic stridor and wheeze. But usually vascular slings we see in children who are syndromic. We see they've got other cardiac problems. And this patient did not present with any problems with feeding at all. There was absolutely no vomiting and no choking. Next. Could this be tracheomalacia that is associated because, he had so many recurrent lung infections? Or also we know that tracheomalacia is associated with severe laryngomalacia and of course secondary due to any vascular sling. But usually tracheomalacia presents more with wheeze unless you have a proximal tracheomalacia, and that could present with stridor. Next. How about subglottic stenosis? Yes, definitely subglottic stenosis presents with biphasic stridor, and this boy had a history of intubation, but he was only intubated for 1 day, and it's a little bit rare to think that he could have an acquired subglottic stenosis. How about bilateral vocal cord palsy? Yes, again, this could present with biphasic stridor, but bilateral vocal cord palsy usually presents with very severe upper airway obstruction requiring tracheostomy. Last but not least, and I know some of you all did choose this, post-infective bronchiolitis obliterans. So in Asia, in Malaysia, we do see this quite a bit. If this patient had a severe RSV infection, then you could actually end up with having some sort of a PIBO. But in this patient, when he was well, hardly any wheeze was heard, and he really didn't have any cough or any persistent symptoms in between when he was well. So for us, when we saw him, we thought that, yes, this was a congenital airway anomaly, and we needed to further investigate. So over to Ek to continue with the case.
So after the January admission, we reviewed him in clinic 2 weeks later, and this is how he looked like. So he was having some nose block at that time, but there was no shortness of breath. There was no noisy breathing. He was feeding as usual, and he was active and playing. He was his respiratory a bit fast, 40 breaths per minute with mild intercostal recessions, but he was saturating well in air, and there was no obvious biphasic stridor at this point of time. So we'll move on to the next poll. So what shall we do next?
That's right. I think giving the
Okay. So what should we do next? We will have the poll first. Okay.
Yes.
So what do you all want to do next? What do you all think? It's very interesting. This boy, he's got such a vivid history, but in between, when you see him, there's hardly any noise. So should we do a contrast enhanced neck and thorax? Don't forget, you must always include the neck because we were looking at a biphasic stridor. Should we do a CTA? Should we do a pH probe, flexible bronchoscopy, rigid bronchoscopy, all of the above, or maybe none of the above, because he looks so well when he, in between. Okay. So I can see some questions in the poll, questions in the chat box, which I will address later on. Okay. So more than 50% have already answered. So let me end the poll. Let me share the results with you all. So it seems that we are also a little bit split. So majority of you all think that the first should be flexible bronchoscopy. Some of you all also think that the CT neck should be the neck, CECT of the neck. Some think a CTA. And there's some who also think that none of the above and all of the above. Okay, so I will now pass the stage over to Prof. Gary to see what is the editor's choice of his investigation that he thinks to be the most suitable.
Right, thank you, Anna. I think Professor Basil goes through very clearly about the potential differential diagnosis and go through all the clinical features. I mean, we see lots of patients with all types of airway noise. And the majority of them are usually related to a viral infections, whether it's in the upper airway or lower airway. And it will usually happen once or twice. And there may be infants or young children have recurrent episodes. But I think the giveaway of the diagnosis of this child is the characteristic of the noise, the age of presentation. And also, I think it's clouded by now most children at that age will get some sort of infections, that be it RSV or metapneumovirus, that of course will give them an acute episodes of airway infection leading to some noise. But when you add everything up together, this child appeared to have an underlying congenital abnormality that we need to figure out what it is and how to deal with it. And of course, in terms of as a good clinician, we should always think of the sequence of investigation. I think it's a little bit of cheating if we say we're gonna do everything. And I believe probably for this particular patient, none of us really would not choose the choice of do nothing. So it's a matter of sequence and what investigation would likely to give you the highest yield of the diagnosis. So first, the CT scan, of course, would help to look at the pathology of the lungs and also obvious abnormality of the airway, particularly the lower airway. While the flexible bronchoscopy will give you very good view of the upper airway and also the dynamic movement of the upper airway, the larynx, the cords, and also, putting down the scope would enable you to obtain samples for microbiological investigations. And of course, the CT with angiogram will give you good picture of the vascular abnormality that may encroach on the airway, resulting in abnormal noise. And rigid, of course, more for that you have to do some practical intervention. It's probably not indicated at this moment. And now at the end, probably two things would be considered most diagnostic or most useful in the diagnosis of this particular child would be the CT and the bronchoscopy. And of course, just like many conditions that we want to investigate, in general, doing the imaging is quickly and easier while arranging an invasive type of investigation like bronchoscopy will take a little bit of time. So probably the combination of CT plus the flexible bronchoscopy would be my choice of investigation in this child in order to establish the diagnosis. And then I'll pass on to...
Yeah. Thank you, Prof. Gary. Yes, we proceeded with a CT chest and neck CT angiogram in last February. It was reported having an aberrant right subclavian artery arising from the aortic arch, distal to the left subclavian artery. This aberrant artery passing posterior to the esophagus and trachea. Otherwise, there was no stenosis of the right subclavian artery, no tracheal narrowing. They also reported right medial lobe consolidation.
So, do we think that this CT scan has actually solved the mystery? Could it be that this is the vascular ring that is causing all this child's problem? So definitely we know that if you have a double aortic arch or you have a right aortic arch with a remnant of the left arteriosum, the ligamentum arteriosum, yes, it can cause a noisy breathing or his biphasic stridor. But this child actually has an aberrant right subclavian artery. And if you look at the aberrant subclavian artery, it actually normally presents, it's normally benign. And if it ever were to present, it will normally present with some occasional swallowing dysfunction and does not require any treatment. And even in this CT scan, we could see that there was actually no indentation of the trachea at all. So we didn't think that this was the answer. So we had to go back and look at the CT for ourselves again and to see what was the problem.
Yeah, so we had a second look on a CT scan again, the neck and the chest. We found that there's a narrowing of the subglottic region, and below that, the trachea was normal. So our radiologist reported that the narrowest part of the subglottis was about 3 mm. We also proceeded with a flexible bronchoscopy under the GA. A few days later, after the CT scan, here I'm showing the short video clip of the bronchoscopy. And we actually screwed through from the nose down to the lower airway using a scope with an outer diameter of 3.1 mm. So I'm showing you the railing, started with larynx. This is the epiglottis, and this is the area epiglottis flows. And you can see the vocal cords, the V-shaped vocal cord. So here's go. The bottom part is the anterior and the top part is actually the posterior. So you can see there's no obvious laryngomalacia. And we advance further down to the vocal cords and then subglottic region. You can see that's a prominent anterior and lateral shelves of the glottis. Also, the mucosa is smooth. And this whole subglottic area looks in an elliptic shape. And when further scope down to the trachea, there's no obvious tracheomalacia. So this is the trachea, this is the pars. There's no complete ring. Yeah. And there's also, okay. So I hope you can see that actually the subglottic space is actually narrow with a prominent anterior and lateral shelves with smooth surface, mucosa surface. And would like to show here to compare to a child about the same age who has a normal subglottis. This is how it looks like. Okay, but this is anterior and this is posterior. All right. So it's actually more convex. It is not as narrow as our earlier child. Okay, so our final diagnosis is congenital subglottic stenosis. And during our last review last month, when he was 16 months old, this is how he is. So we can still hear the loud sido during but during exertion or when crying. But otherwise, most of the time, according to mother, he was actually fairly well and no obvious noisy breathing.
Thanks so much, Ik.
Yeah.
Okay, so we'll pass the floor over to Prof. Jayanti, who will go through this subglottic stenosis, and particularly because I'm sure many of the audience will be wondering, is this congenital, is this acquired subglottic stenosis? So maybe we can hear from Prof. Jayanti now. Thanks, Jayanti.
Thanks, Pravana. So before I dive into congenital subglottic stenosis, let's just take a look at the anatomy. So the cricoid cartilage, as you know, is a hyaline cartilage and it's part of the laryngeal skeleton. So the term cricoid is a Greek word, krikos. It means a ring shaped. So in addition to contributing to the structure of the larynx and maintaining the patency of the trachea, the cricoid also serves as an important attachment for laryngeal muscles, for cartilages, for ligaments that's involved in phonation. Next slide, please. So this picture, I just want to demonstrate that it is, the shape of the cricoid. It has a narrow anterior lamina. If you can point to it, the arch is much narrower anteriorly, and and posteriorly, the lamina is quite broad posteriorly. So these are different sections taken through the cricoid, and you can see, the caliber of the airway changes as you go from top to bottom. Now, at D is where we took the images at the cricoid outlet. So you can very clearly see here the cricoid is circular in nature on a CT scan. But when we compare it to our patient's cricoid, you can see here that the cricoid is elliptical in shape. The airway is elliptical in shape. Next slide, please. So the cricoid, as we know, is part of the subglottis. So where is the subglottis? It extends from the insertion of the conus elasticus, which is the lower end of the vocal folds, to the inferior margin of the cricoid cartilage. Next slide, please. So this slide is just to show that the configuration of the larynx is more cylindrical in the adults compared to a much funnel shape in infants. So in children younger than 8 years old, the narrowest portion of the airway is at the cricoid cartilage. Next slide, please. So this slide is to highlight that the airway is growing as the child is growing. The length of the trachea is doubling, the diameter triples, and the cross-sectional area increases by 6-fold from an infant to an adult. Next slide, please. So let's go into subglottic stenosis. What is the definition? So it is the subglottis. There's a diameter of less than 4 in a neonate or less than 3 in a premature baby. We can classify this as congenital subglottic stenosis. It is the third most common congenital anomaly of the larynx after laryngomalacia and vocal cord paralysis. And the most common laryngeal anomaly that's necessitating a tracheostomy in a child less than a year old. But the true prevalence of this condition is difficult to determine because many cases are aggravated by an emergency intubation, leading to the so-called acquired on-congenital subglottic stenosis, which is most likely in our case. Next slide, please. So the pathogenesis of subglottic stenosis is due to incomplete recanalization of the laryngeal tracheal tube during the 3rd month of gestation, which leads to different degrees of subglottic stenosis. So the worst form really is the complete laryngeal atresia. And we know that congenital subglottic stenosis is usually a cartilaginous in nature. Next slide, please. So this condition is histopathologically classified by Hollinger either as cartilaginous or soft tissue. And as I said, the cartilaginous tends to be congenital in nature, where you can see there's various different shapes it can take. And it can also be of normal shape, but small size. Next slide, please. Okay, some distraction. Okay, the most common form of congenital subglottic stenosis is a thick anterior lamina or a generalized thickening of the cricoid ring or an elliptical cricoid. So this is a histopathological picture of an elliptical cricoid. Next slide, please. Endoscopically, this is what it looks like. Picture A is a prominent anterior cricoid. You can see where the pointer is. Picture B is a generalized thickening of the cricoid. So it's almost oval shape, but it's much, a circular shape, but it's much smaller. And the third commonest is the elliptical cricoid, which looks very similar to our patient. Next slide, please. So in acquired subglottic stenosis, this is what it looks like endoscopically. So you can see it looks quite different from congenital, where the mucosa here, you can see the scarring, it's much irregular, and it's graded, according to how bad the stenosis is from grade 1 to grade 4. So when we compare it to our patient, you can see that the mucosa in our patient was much, it was a normal mucosa. Next slide, please. So usually congenital subglottic stenosis appears in the first few months of life. The stenosis typically is not evident until the child develops an acute inflammatory process, such as croup, like our patient, and biphasic stridor with or without symptoms of respiratory distress is the most common presenting symptom. They can also have a barking cough with a normal cry. And we would suspect congenital in nature if the symptoms are recurrent or if they have had a prolonged episode of croup beyond the normal duration. Next slide, please. So this is an interesting systematic review on bronchoscopy findings in a recurrent croup patients. And you can see in among the pooled patients of 885 patients, only 8.7% had significant findings on their bronch, which included subglottic stenosis, bronchotracheomalacia, reflux changes, and vocal cord pathology. So yes, the pickup rate is low. However, you cannot, especially in a recurrent croup, you really have to further investigate, like has already been discussed, with either CT scan or a bronch to rule out other pathologies. So if patients are referred to me as an ENT surgeon, I do a rigid bronchoscopy. And what's the advantage of a rigid bronch is that we can palpate the subglottis to, we can differentiate. When it's really firm means it's a cartilaginous problem, which makes it a congenital. And I can also size the subglottis using endotracheal tube. So you can see here in this table, the top, where it's highlighted in the red box is where our patient falls under the 9-month to 2-year age group. And in this age group, they should take a 4.5 ET tube. So a 4.5 ET tube has an external diameter of 6.2 millimeters. So if you remember from the history that the child had a bronch, the bronch, flexi-bronch was 3.1 millimeter bronch, could pass through the subglottis, just about pass through. So we can assume that the subglottis is about 3.1 millimeter, which falls under between grade 1 to grade 2 subglottic stenosis. So that's about roughly how you can calculate roughly how bad the stenosis is. Next slide, please. So what do we do with these children? How do we manage them? So you first need to see, is this a mucosal problem or is this a skeletal problem? So the mucosal is treated medically, whereas the skeletal problem is treated surgically. Next slide, please. So, presently children who experience recurrent croup symptoms, they receive a variety of treatments. There's no standardized treatment for these children. There's very little data in the literature as to what's the best treatment and how to manage them and how to keep them at home, really. But definitely you need to get the parents to determine, are there any potential triggers at home that they could avoid to trigger these recurrent croup. The literature does suggest that a single dose of dexamethasone has shown to be effective in reducing the overall severity of croup. Prednisolone is not as effective as dexamethasone, but another equally effective treatment is nebulized budesonide. But again, you need a nebulizer at home, and budesonide is much more expensive compared to dexamethasone. But more recently, Soa et al. In 2023, in their papers, are advocating the use of prophylactic inhaled steroids for recurrent croup. However, in their paper, they did not mention what is their preferred choice of inhaled steroids, what sort of dose, and how long should the patient be on it to avoid, coming into the hospital. Next slide, please. So one thing to point out is if it's congenital subglottic stenosis, you cannot dilate the subglottis. Okay, so these children, you don't put them through endoscopic balloon dilatation. That's definitely the wrong thing to do. So they really, you first have to grade them, whether it's grade 1 stenosis, 2 or 3. Grade 1 stenosis, most times, watchful waiting approach is taken because, as we know, that the airway is growing, and they will probably grow out of this problem. However, grade 2 and especially grade 3, the child may end up requiring a tracheostomy to secure the airway, and then I come in and do, either an endoscopic or an open surgery to widen the cricoid. So endoscopically, we can insert a graft, either anterior or posterior. Next slide, please. Open surgery is either expansion surgery or resection. So expansion is where we harvest graft from the rib and put an anterior or anterior and posterior graft. And resection means you remove the cricoid and do a primary anastomosis. So that really, covers the management of recurrent croup. Thank you very much.
Thanks so much, Jayanti. So I'll just have the last say for today before we get to the questions from the audience. So this is a 16-month-old boy. He's ex-premature, but he presents with recurrent, if not, basically, I think he actually has persistent noisy breathing. It's just that the parents never really picked it up or never really complained to it unless you ask. And interestingly enough, this only happened after a very severe RSV and a COVID infection. But to unravel the mystery of this child's noisy breathing, as mentioned repeatedly by all our speakers, is you got to know what is the noisy breathing. If one is not able to identify what is the type of noisy breathing, you will not be able to determine where the level of obstruction is. And where the level of obstruction will actually lead you to decide what type of investigation you would like to do, and as well as obviously what is your differential diagnosis. So for us, our differential diagnosis was congenital airway stenosis. However, when we looked at the records of this patient, I know in the poll, many of you all did not say this, but many of the doctors actually label this as a recurrent croup. And hence why you can see not only Prof. Basil, but Prof. Jayanti as well talked about this recurrent croup, because it is actually a diagnosis of exclusion. You look carefully to exclude any form of airway anomaly before you label this child a recurrent croup. This child also had laryngomalacia, so many people actually thought that this could be just a child with laryngomalacia and just having too many infections. But again, as I mentioned before, laryngomalacia, the natural history of laryngomalacia does not fit this child. So this is not the diagnosis for this child. And once we have made we think that this is next once we think that this is a congenital airway stenosis, what was very surprising was our in-between reviews. And that's why we actually showed you these videos, because there he is, he's smiling away. And again, these parents would not tell you very much. In fact, even at the last video, when the last time when we saw, they were like, "Oh, doctor, everything is okay." And we're like, "Oh, is it? We didn't do anything, actually. We just made the diagnosis." But, as you spend a little bit more time with him, you realize, hey, he's actually got noisy breathing. And we had to convince the parents that, hey, your child actually has something wrong with them. So that was actually quite interesting as well. So, what parents say, you sometimes have to take it with a pinch of salt. Last but not least, I think that many of you all may still think, oh, this is still acquired. But I think Prof. Jayanti very clearly described the difference between congenital and acquired subglottis. So we really think that this is congenital subglottis. And of course, what is his best management at this time? If we can go to the next slide, because we know that if we think that this is congenital subglottic stenosis, definitely we are not going to ask for any form of dilatation. He also seems to be fairly well in between. You could see from Prof's slide that the weight was actually going up as well. So, what could we offer him if the mom is keen, or she thinks it's severe enough? Then we could ask them to use a nebulized budesonide. The doses are there. As you can see, these doses are very similar to the treatment of acute croup. Yeah, so it's not rocket science really, these doses, but this is what people have suggested. If it's too difficult, one could suggest the use of oral dexamethasone when they hear the noise, and it can be taken up to a maximum of twice daily, and if needed. But however, parents must be educated properly, as in they need to know when to come in. And I think that's the tricky bit. Where some physicians, some doctors may be very nervous to send them with this type of medication, because these patients may actually come too late, because the parents think that they have all of this and they can manage, and they don't really recognize that this child is critically ill. So with that, I hope all of y'all are convinced. I hope all of y'all have learned something interesting. I know we did as the managing team. Next slide. Okay, so we have a special thanks, especially to the Secretariat of the Malaysian Thoracic Society, who are up here and helping us with this session. Next slide. We also would like to do a few advertisements for today. And I think maybe I'll pass it over to Daniel. Daniel, you can take over.
Thank you. Thank you very much, Anna. And thanks for audience for attending this meeting. I'd like to take this opportunity to invite you all to come repeat again to visit this APPS grammar again next month. It's the last day of the month of May, on the last Friday. Professor Mahesh Babu will lead his team with panelists from all over Asia to discuss an infant with recurrent wheeze infants. So I'm sure that it will be a more interesting and different scenario from today. So I will invite you all to mark your diary the last day of May, the last Friday, to visit our website to join the Zoom in our grand round. In Singapore time is 7 p.m. So again, and also I'd like to invite you to an international meeting that will be held this summer in Portugal. If I can, next slide, it will be the second Congress of the International Society of Pediatric Respiratory Disease, which is and we will cover a wide range of topics, and hopefully doctors from Asia, Europe, and US can join together in a common platform to share the knowledge and promote the development of pediatric respiratory medicine. So with this, I'd like to thank the audience for attending the meeting. Of course, I thank all the speakers, the presenter, and the panelists for the excellent presentation to tackle not uncommon disorder requiring croup with very practical advice on daily management. So thank you very much, and wish you all a very nice weekend. Thank you. Bye-bye.